Parth, try sharing your PowerPoint, man.
Okay, sir.
Fahad, put it on slideshow, please.
Yes.
Sorry, friends. Sorry for making you wait. Looks like Delhi is a lot of rains and floods, so the faculty from Delhi will not be able to join. He will try to join. Let us hope he's able to join. So it's just few minutes beyond 8 p.m. So we will go ahead with the case presentation. Ladies and gentlemen, we have the case presentation by Dr. Parth. Parth is from All Institute of Medical Sciences, Rishikesh. He is kindly contributed by Professor Amit Gupta, sir, and he is also with us today. Warm welcome to our own faculty, Professor Sahai, sir, Khanna, sir, and I could see few other faculty. Hope to start the discussion. So we will be. Can you have the part? Can you make it full screen? Welcome, Gupta, sir. Narendra Gupta, sir, also I could see. Part. Parth, are you able to hear me?
Hello. Am I audible, sir?
Yeah, Parth, you are good to go.
Yes,
Parth,
sir.
you please introduce yourself. You are assistant professors, you are head of the unit and the head of the department, and start your presentation. I request you to make it full screen, Parth.
Okay. Sir, I've made it full screen. Is it not visible now? Is it visible?
Some reason we are getting only the regular mode. Can you try doing it again once for us? Or and go back to the regular mode and try screen share mode.
Okay, sir. So now
Other faculty, are you able to see the screen, full screen view, sir? Maybe
No,
I
sir,
have
yes.
poor network or
No.
something.
okay, sir, I share once again, sir.
You please, yeah, you close the PowerPoint now. Go to the screen share of the desktop.
Yes, sir.
Now again, it is the same. You please try going for making it view mode, slideshow mode.
So now is it slideshow mode?
No, please unshare this. Please listen to all the steps carefully what I am trying to tell you. Please unshare this. Please
Yes,
close
sir.
the PowerPoint on the desktop.
Okay, sir.
Okay, now press the screen share mode. What are the things you are seeing?
Just I have shared. It is a.
Share desktop is there.
Yes, sir.
Please press that.
Okay, sir. Desktop is.
Yes. Now open the PowerPoint.
Yes. So is PowerPoint visible, sir? Is it in full screen, sir?
You are not clicking the right one, Dr. Parth. You have to come back. You are running through or you are not in the right mode. Please close this, unshare now. Once again, close the PowerPoint. Close all the files in the desktop, whatever things which you have kept open, please close everything.
Okay, sir.
Have you done that?
Yes, sir.
Now press the screen share mode.
Yes, sir.
What are the things you are seeing on that options?
Sir, option is entire screen, then application windows, then post attendee Zoom and search bar.
First one, what is that?
First is entire screen, sir.
Click that entire screen.
Okay, okay. Yes, sir. I have.
Now open the PowerPoint. Now go down onto the right corner. You see the screen share mode. Yes. Now we are good to go. Good luck to you.
Okay, sir. Thank you.
All the best. Faculty, please take over, sir.
So good evening, everyone.
Yes,
shall I
start.
start?
Yeah,
Good
start.
evening, everyone. Good evening, everyone. Today I'm talking about my story from Department of Surgery at AIIMS Rishikesh, second year postgraduate resident. Today I'm going to present a case of obstructive jaundice, and my moderator is Professor Amit Gupta from Department of Surgery at AIIMS Rishikesh, and our HOD is Professor Som Prakash. So starting with patient particulars, gentleman Mr. X, aged 56 years, a resident of Rudraprayag, Uttarakhand, farmer by occupation, presented to us 1 week back with complaints of yellowish discoloration of eyes and skin for last 30 days, passage of high colored urine for last 30 days, itching over the trunk and extremities for the last 20 days. There was yellowish discoloration of eyes and skin for the last 30 days, which was noticed by the family members, and it was progressive in nature. There is passage of high colored urine for the last 30 days. It was associated with passage of pale colored stools. There is itching over the extremities and trunk for the last 20 days. Patient also has history of loss of appetite and unintentional undocumented weight loss for last 1 month, which was reported by loosening of clothes. Patient has no history of abdominal pain or vomiting. Patient has no history of abdominal distension. There was no history of altered bowel habits. There was no history of melena, no history of fever, malaise, generalized weakness, or joint pain, and there was no history of hemoptysis, seizures, or backache. Patient did not had any history of tuberculosis, diabetes mellitus, asthma, hypo and hypothyroidism, hypertension, or ischemic heart disease. There was no history of blood transfusion, IV drug abuse, or tattooing in the past. There was no history of previous hospitalization, no history of any chronic drug intake, no history of any surgery in past, and no history of any allergy known till date. Patient is a married man which had 2 children. His sleep was disturbed due to the generalized itching. Patient is vegetarian in diet. He had history of alcohol intake 20 years back, which is 7.5 units, that is 75 grams per week, and history of smoking with 18 pack years. There was no history of similar diseases in family. There was no history of any malignancy or malignancy related death in the family. Now summarizing my history, to a gentleman aged 56 years, presented with the painless progressive jaundice and the passage of high colored urine for the last 30 days, with itching over the trunk and extremities for last 20 days, with the passage of pale colored stool, with loss of appetite and loss of weight, with no prodromal symptoms and no known comorbidities.
Yeah, Dr. Paul. So what's your diagnosis just by history? What do you think you're dealing with?
So my disease patient has a case of obstructive jaundice with most likely malignant etiology, and the first differential would be carcinoma head of pancreas.
Okay, you said obstructive jaundice. Why do you think it's obstructive jaundice?
So patient is a case of obstructive jaundice because patient complains of like itching. There are complaints of pale colored stool. There is passage of high colored urine.
What do you mean by high colored urine?
No, as the patient has jaundice, no? So his
Yes.
sclera and all. They say you said no. He's got yellowish discoloration. So that's
Yes,
the first. And why do you think it's obstruction?
Because sir, the symptoms which patient present with, it reads that there is a stasis of bile flow, which was of which these symptoms are there.
Okay,
So
let's go to your first slide.
yes.
Okay, next. Next. Okay, next. Okay, next. No abdominal history of abdominal pain or vomiting. What does that tell you?
So it tells us that means patient does not have abdominal pain, which rule out because there may be two causes of obstructive jaundice. There is one painless jaundice and painful. Painful causes may be because of choledocholitis, or it is pain is also present in abdomen in cases of carcinoma gallbladder.
Okay,
So
that's pain
was
waves.
not
Okay.
yes, sir.
Can CA head of pancreas have pain?
Yes, sir.
Can CA head of pancreas present with pain? You said
Yes,
no.
yes, sir. CA head of pancreas can also present with pain in two cases. If this pancreas involve the retroperitoneal nerves, or
Okay.
if there is
What about vomiting?
ductal pressure.
What
So
does vomiting tell you?
vomiting basically indicates that if there is no history of vomiting, it indicates that there is no history, there is no features of gastric outlet obstruction, which might be present in the cases if the carcinoma head of if the means tumor size grows and it obstructed at the level of duodenum. The patient might present with gastric outlet obstruction, but in this patient there were no such.
So gastric outlet obstruction in CA head of pancreas. Anything else? Any other condition where you can have vomiting in periampullary carcinomas? You can
Sir,
rule it out. Very common vomiting in that case.
yes, sir. So vomiting might also be present if means if there is cases of like acute cases of acute cholecystitis, vomiting might be present.
No. You ruled out. You said it's. I'm
Yes.
talking about periampullary carcinomas which have vomiting. You said one CA head of pancreas.
Okay, sir, duodenal carcinoma.
Why? Why duodenal?
Duodenal carcinoma will obstruct the means the flow, means the alimentary tract. So it would be the most common periampullary that will mostly means may present with the gastric symptoms.
Duodenal carcinoma because of. Okay, why do you think CF head of pancreas presents with gastric outlet obstruction? How can they do present with gastric outlet obstruction? Why?
So if the tumor grows, if the
Yeah.
tumor grows into a size such that it causes a mass effect over the duodenum, then it might lead to.
But that's quite late.
Yes.
Anything earlier than any earlier cause? If it infiltrates into the duodenum.
Yes, sir.
Okay. Abdominal distension. Why do we ask for that?
So it basically rule out that it is not like in cases of if patient presents with metastatic cases when there is ascites also, so there would be abdominal distension present, but it was not present in this.
Okay. Altered bowel habits, melena. When do you expect melena to happen in obstructive jaundice?
So mainly in periampullary carcinomas and duodenal carcinomas, where there would be melena would be present because the tumor.
All periampullary carcinomas present with melena.
Yes, sir.
All periampullary carcinomas present with melena.
No, sir. So periampullary carcinomas mainly the ampullary and the duodenal carcinomas present with the melena.
So you asked for melena, but you didn't ask for bleeding per rectum, hematochezia. Can that happen?
Yes, sir, that might be present in cases. If it is in late stages, if like there are liver mets, because of which there is cirrhosis and portal hypertension, or the second can be if the mass itself is compressing the portal vein and there is portal hypertension, so there may be portosystemic anastomosis might bleed in the rectal areas.
Oh, come on. Oh, come on. Don't take it into portal hypertension. How many cases of obstructive jaundice have you seen portal hypertension?
Very rare.
There are other causes, no? Bleeding. Suppose
Yes,
if you are restricted yourself to CA periampullary, can it be CA stomach?
yes, sir.
It can. So you can have melena when there's CA duodenum.
Yes, sir.
Right? If the carcinoma head of pancreas infiltrate into the duodenum, you can still have it. You can have it in ampullary type of malignancy.
Yes, sir.
So you can still have. Okay. Okay. Fever, malaise, generalized weakness. He's got weight loss. Look, malignancy of periampullary carcinoma, and you said there's no history of generalized weakness. Unlikely.
Yes, sir.
Right? There must be some sort of weakness. What about joint pain? What do you ask for joint pain?
Sir, basically joint pains might indicate that if there are metastatic bony lesions, there may be pain in the back
So
or
bony
leg.
lesions, metastasis to bones present with joint pain. Or do they present? How do they usually present mets?
Mets usually present with bony mets.
They present with bone pain. Why joint pain?
Bone pain. Okay, yes.
History of hemoptysis, seizures, backache. Why hemoptysis?
So hemoptysis is just to rule out that there is no history of TB or something like, because it is pertinent
There's
very
no history
common.
of tuberculosis.
History of
Any
tuberculosis.
other reason in this case you've asked? Tuberculosis is way out from this
Yes,
diagnosis.
so they might be like if a patient might have a means history of means bleeding from the mouth, but that could be hematemesis, not hemoptysis.
Okay,
Parth.
so yeah, sir, please.
Parth,
Yes.
in which condition we will get painful jaundice, painful progressive jaundice? Painful progressive jaundice.
Painful progressive jaundice might be present in cases of carcinoma gallbladder, sir, which might originate from the neck of the gallbladder. It would be painful and there would be a progressive jaundice.
Any other condition? Most
Uh,
common.
Sir, in cholangiocarcinomas,
Hilar cholangiocarcinoma.
cholangiocarcinomas, yes, sir.
In which jaundice we get jaundice with a back pain?
So
Severe
jaundice,
back pain.
yes, sir. The voice. Can you please repeat the question, sir? Voice.
In which condition you will get jaundice with a back pain?
So jaundice with back pain may be present in cases of carcinoma pancreas itself. And
Which portion? No, which portion?
means head of the pancreas, sir.
Head of the pancreas.
Yes.
In which condition you will get painful jaundice with fever?
Painful jaundice with fever might be present in choledocholithiasis, sir, if patient associated with cholangitis. And yes.
And painless intermittent jaundice?
Painless intermittent jaundice would be present in cases of, sir, in periampullary carcinomas, if there are choledochal cysts.
Why
that
there is
also-
intermittent jaundice in periampullary carcinoma?
Because in periampullary carcinomas, basically, when it obstructs the ampulla, intermittent there is sloughing of tumors, which releases the obstruction. So the jaundice appears, and when there is a sloughing of the tumors, along with so there is a relief of the obstruction, and the jaundice also gets relief.
You have mentioned that there is no history of fever, malaria, weakness, and joint pain. What is significance of these points?
So fever basically indicates that patient fever in this case scenario, fever can be a symptom of cholangitis. So fever is not present,
Okay.
patient was not in cholangitis.
So what is Charcot's triad?
Yes, sir. Charcot's
What
triad
is Charcot's triad?
triad of cholangitis, which includes pain, jaundice, and fever, which indicates the
More
patient is
specific. More specific. Which type of
sir,
fever? Which type
yes, sir.
of jaundice?
It's intermittent fever, intermittent fever, jaundice,
Intermittent fever, intermittent pain, and
and
intermittent jaundice.
jaundice. Yes.
And what is Raynaud's pentad?
Yes, sir.
Raynaud's pentad.
Sir, if it includes
Raynaud's pentad.
yes, sir. If there is altered mental sensorium and patient is in shock, then it's if these two categories added in the with the pain, jaundice and fever, then it is fantastic.
Proceed.
What is the difference between surgical jaundice and obstructive jaundice?
So surgical jaundice is basically any jaundice that needs a surgical intervention. And obstructive jaundice is in cases where there is obstruction in the biliary tract.
So what is that surgical jaundice?
Means any
Where you
jaundice.
can operate?
Surgical jaundice means includes every jaundice that needs a surgical intervention. For example, we can see if there is jaundice because of hypersplenism. So that might require splenectomy. So that will be in category of surgical jaundice, but that would not be obstructive jaundice.
So by doing a splenectomy, you will relieve the jaundice?
No, sir, but if the cause is prehepatic, like in cases of hemolysis. And in surgical, like in cases of if there is means the obstructive jaundice may also require surgical resections. So they may,
Can you have an intrahepatic obstructive jaundice?
yes, intrahepatic obstructive jaundice can be present. If
In which condition?
sir, in cases if like there is a solitary liver nodule present inside the mainly in the caudate lobe, if we say means where the secondary ductal is radical, if there is solitary liver nodule, these can lead to obstructive jaundice.
What is cholestatic jaundice?
Cholestatic jaundice is there is a stasis of bile because of any factor. So activity function, it can be obstructive. That would be cholestatic jaundice.
Is that intrahepatic obstructive jaundice or not?
Yes, sir. Intrahepatic obstructive jaundice can be present.
This is
Yes, sir.
intrahepatic. No?
Yes, sir.
So anything which is intrahepatic is obstructive jaundice. Anything extrahepatic is a surgical jaundice. You know?
Okay, sir.
Okay. Now, why did you ask the history of blood transfusion?
Sir, his blood transfusion can be means first thing is patient is a jaundice, so we need to rule out if there is any infective etiologies like cases of viral hepatitis, which is which can be transmitted to blood transfusions, and also if there is multiple blood transfusion, it can lead to means trigger hemolysis, and that might also lead to means jaundice.
So if somebody gets a blood transfusion, when he can have the jaundice?
Sir, if blood transfusion was not properly cross matched, so that can trigger hemolysis, and that can lead to jaundice.
When he will have the jaundice? In few hours time, in
Okay.
few weeks time, few months time?
It would be means up to 24 to 48 hours.
In 24 to 40 hours, you will get the jaundice.
Yes, sir.
When you have the viral infection, then when you get the jaundice?
So jaundice would be appear in viral cases. It would be in within 1 week of period, sir.
Within 1 week, you will get the jaundice in viral hepatitis.
Viral hepatitis.
No, it's around 4 to 6 weeks at least, you know?
4 to 6 days. Oh.
4 to 6%. Now, can you tell the jaundice the patient has a yellow sclera, but the urine is white? Can it happen?
Yes, sir. It can be cases in the unconjugated when unconjugated bilirubin is raised. So
Okay.
they would be it will be jaundice in the eyes, but urine would not be high.
What is that called as? What is the jaundice called as?
Jaundice.
Acholoric jaundice. You know?
Okay, acholoric. Yes, sir.
Okay.
Acholoric.
Or in the case of hemolytic anemias, you can get that.
Okay.
Now, can you tell the urine is yellow, but the sclera is white? Urine is yellow, but the sclera is white. Any condition for that?
Sir, if the bilirubin is not that raised, means it is not deposited in the bilirubin, but it is excreted in the urine. Or if urine is, so you're getting high colored urine,
Yeah.
it can
Yellow
be
and high color is the same, almost the same thing. No? The patient cannot distinguish between the yellow and the high color urine.
patient. So most common of the causes of high colored urine, if we say the patient had been dehydration, so he would have high colored urine, but there would be no yellowish discoloration.
Any medicine which can color the urine?
Rifampicin, sir.
Any other more common drug which everyone takes can have the yellow urine? Almost everyone takes that, yeah. Simple B complex, you know?
Okay.
Simple B complex colors the urine. You know?
Okay.
Did you ask the history of night blindness in your patient?
No, sir, but it would be visible because of
Did you ask the history of that?
no, sir.
Can it happen in your patient?
Yes, sir. It will be happening.
How it can
Because,
happen?
so because of deficiency of vitamin A, because of which is a fat soluble vitamin, and as there is no bile in the alimentary tract, so fat soluble vitamins will not be absorbed.
You were telling about the causes of pain in the carcinoma head of pancreas. So one, you said there is a retroperitoneal involvement is there. What else?
So there will be increased intraductal pressure that might also lead to, because of obstruction, that might also lead to pain.
What is the predisposing factor or pre-malignant condition for the carcinoma head of pancreas?
So predisposing factors means chronic pancreatitis can be one of the factors.
So can
And
it be the pain because of that chronic pancreatitis only?
yes, sir, it might be.
So that is in fact the first etiology, the pain in the case of the carcinoma head of pancreas. The chronic pancreatitis is itself is a cause for the carcinoma head of pancreas.
Okay.
Now, why do you get a jaundice in a patient with carcinoma gallbladder? What is the reason?
Sir, in cases of carcinoma gallbladder, if the it is originating from the neck, it might infiltrate into the CVD or CHD, and if it is originating, it can also cause a mass effect over the CVD, obstructing the CVD. Plus, if there is carcinoma gallbladder, it might also involve the lymph nodes around the porta hepatis. There might also be liver metastasis. So these can be causes of jaundice in the case of carcinoma.
Can they be associated choledocholithiasis?
Yes, sir. They can be associated carcinoma gallbladder with CVD stone. Yes, sir.
What is the percentage of that having the cholelithiasis and choledocholithiasis in
10%.
carcinoma? In cholelithiasis?
Cholelithiasis is present up to 70 to 80% cases, sir.
Okay. Somebody else can take over.
Parth,
Yes, sir.
what are the post-hepatic causes for jaundice? Surgical causes, post-hepatic causes of jaundice.
The post-hepatic causes of jaundice can be distributed in four types. One is complete jaundice, one can be intermittent jaundice, one is a chronic incomplete jaundice, and segmental jaundice. The causes can
I'm
be
asking causes.
causes. Yes, it can be choledochal cyst, choledochal lithiasis, carcinoma head of pancreas, periampullary carcinoma, and sclerosing cholangitis, parasitic infections. These can be extrahepatic causes. Cholangiocarcinomas.
Prehepatic causes for jaundice.
Prehepatic causes can be, sir, in cases of hemolysis. Say it is distributed, in cases of hemolysis, there will be prehepatic jaundice, which can be distributed into two types. It can be either congenital or acquired. In congenital cases, there might be some hemoglobinopathies like hereditary spherocytosis, thalassemia, sickle cell diseases, and or there can be membrane disorders in cases of means the change in the shape of the PRBC because of G6PD deficiency or pyruvate kinase deficiency. And there can also be acquired causes because of drugs, infections.
What are the hepatocellular causes for jaundice? Hepatocellular causes.
Yes, sir. So hepatocellular causes can be in cases of like viral hepatitis. Patient might develop jaundice. Or there is a drug-induced hepatitis, then patient might have jaundice. Means
Okay.
any disorder that can cause acute. Yes.
Surgical cause.
In surgical causes, sir, this will be means choledocholitis, carcinoma head of pancreas, periampullary carcinoma, choledochal
No,
cyst.
no. Carcinoma of head of pancreas that come under post-hepatic causes. Hepatocellular.
Oh,
Hepatocellular carcinoma is the cause.
Okay, so it might in hepatocellular carcinoma patient might have, but it is.
So parts it can be a intrahepatic cholangiocarcinoma as well, and
Yes.
hepatolithiasis, right?
Okay.
Proceed.
Sir, can we move to examination part?
Yes, proceed. Hello.
Okay. So moving towards the examination. On examination, patient was conscious and oriented to time, place, and person. Patient was average bit and nourished. He was well hydrated. Weight of the patient was 64 kg with height of 168.5 centimeter and BMI 22.67 kg per meter square. With a ECOG score of 1 and Karnofsky performance score of 90. Patient vitals were he was afebrile to touch. Pulse rate is 63 beats per minute with in a right radial artery, regular rhythm, good volume with no radial or radiofemoral delay. BP of 133 by 80 millimeter of Hg in supine position in right arm, respiratory rate of 18 breaths per minute in abdominal thoracic pipe, saturation 98% on room air. On general physical examination, patient was ecteric. Pallor can't be commented upon because of icterus. There was no clubbing, no cyanosis, no edema, no peripheral lymphadenopathy, and left supraclavicular lymph nodes were not palpable. Neck veins were not visible. There was no swelling palpable in the neck. There were scratch marks present over the trunk and the peripheries, and there was no signs of any chronic liver disease. Coming to systemic examination, on CNS, there was no focal neurological deficit. Reflexes were intact. Power of 5 by 5 in the limbs with GCS of 15 by 15. Respiratory rate, bilateral air entry was present with normal vesicular breath sounds and no added sounds. On CVS examination, S1, S2 was heard and there was no murmurs. Musculoskeletal examination, there was no skeletal deformities or no gait abnormalities. Coming towards the per abdominal examination, on inspection, there was a diffuse bulge seen over the right hypochondrium. Skin was yellowish in discoloration. All quadrants were moving proportionally with respiration. Bilateral pharynx appears to be normal. Umbilicus is inverted and in midline, and scratch marks were present over the abdomen. There was no dilated veins, sinus, or fistula. There was no visible peristalsis and pulsations. Hernial orifices, there was no visible cuff impulse present. Inspection of the back and spine was unremarkable, and external genitalia appears to be normal. On palpation, on superficial palpation, there was no local rise of temperature or tenderness. A vague globular lump of approximately 5 into 4 centimeter palpable below the costal margin at the tip of the ninth rib. Smooth surface, firm consistency, moves with the respiration, moves side to side, and upper border was not palpable. Liver and spleen was not palpable, and there was no other lump palpable. There was no tenderness on deep palpation. Hernial orifices were intact. There was no fluid thrill, no paraspinal tenderness, no renal angle tenderness or fullness. On percussion, liver span was 11 cm in mid-clavicular line. Tympanic node was present. There was no shifting dullness. Bilateral renal angles are resonant, and auscultation bowel sounds were present. On perrectal examination, perineal skin was normal. There was no fissure, fistula, induration, or tenderness. Digital rectal examination, there was no growth felt. Mucosa was freely mobile. Finger fecal stain was present, which was pale stools. No blood stain present. No prostatomegaly. On summary, a gentleman aged 56-year-old presented to the painless progressive jaundice with a passage of high-colored urine for the last 30 days, with itching over the trunk and extremities for last 20 days, with passage of pale-colored stool, with loss of weight, loss of appetite, with no prodromal symptoms, with no comorbidities. On examination, he was ecteric with a palpable gallbladder. There was no free fluid or supraclavicular lymph nodes palpable.
Hello, go to the first slide. Inspection.
Okay.
Okay. You have not mentioned about left supraclavicular lymph node.
I'm examining a lymph node examination, sir.
No.
Okay.
Examination of the left supraclavicular lymph node, spine, external genitalia, renal angle, that comes under abdominal lump examination. That is in part of the abdominal lump examination. What are the positive points in inspection?
Sir, on inspection, there was a diffuse bulge which was seen over the right hypochondrium. Yellowish discoloration was seen on the skin, and there were scratch marks present over the skin.
So, what does scratch mark suggest? Which is the commonest site of the scratch marks in case of obstructive jaundice?
Sir, in obstructive jaundice, commonest site is extremities, and edema ought to be present over the trunk.
Why there is itching in case of obstructive jaundice?
Sir, in cases of obstructive jaundice, the exact cause of itching is still obscured, but there are certain proven theories, like there is one, if there might be deposition of bile salts in the mast cells of subcutaneous tissue, and these deposition triggers the mast cells, triggers the mast cells, which releases the histamines, which might cause itching.
Next slide, please. No visible peristalsis or pulsation. In which condition you will get the visible peristalsis?
Sir, if the patient, the cases, if patient presents, for example, with gastric outlet obstruction, so there might be visible peristalsis in cases of, in that cases, if there is infiltration into duodenum or there is mass.
Repeat again, please.
Sir, means if the patient presents.
Please
features.
listen my question.
Yes.
What are the causes for visible gastric peristalsis? In which condition you will get visible gastric peristalsis?
Okay. So visible gastric peristalsis might be present in the cases of obstruction.
Your answer should be more specific. These
Have
questions
you
are
seen-
simple questions.
You see in pyloric stenosis, pyloric strictures?
Yes, sir. It may be present in gastric outlet.
One is a pyloric stenosis, second is a transverse
Pyloric.
colonic malignancy, and step-ladder pattern in case of small bowel obstruction. So, what
Okay.
is the difference between peristalsis of the hypertrophic pyloric stenosis that from the transverse colon malignancy? Is there any differentiating point between these two?
Yes, sir. So the side of the side means direction of the peristalsis. In the cases of in cases of gastric outlet obstruction, it will be from the left to right. While in cases of if there is small bowel, it would be, or there is transverse colon obstruction or transverse peristalsis, so it would be from right side to left side.
And visible pulsations, in which condition will get the pulsations? What are the types of pulsations?
Visible pulsations might be, sir, if like in cases of means if there is a CLD cases, so there might be dilated veins which might show pulsation, or if the patient is too thin or too means cachexic, so pulsations might be seen from the aorta.
What are the types of pulsations? Not
There is
inspection, palpation.
On palpation, there might be expansile and non-expansile pulsation.
Expansile
And non-expansile
more
pulsations.
specific, not non-expansile, transmitted pulsations.
Transmitted pulsations. Okay.
Okay.
Yes.
So positive finding on your inspection is
So the inspection positive findings were these: diffuse bulge over the right hypochondrium. There was yellowish discoloration of skin and scratch marks were present on inspection.
you are not commented about it moves with respiration or not. That bulge, that
Yes, sir.
visible bulge. You mentioned that all quadrants moving proportionally with respiration, but you are not commented about
But
diffuse
yes,
bulge over the right hypochondrium and it moves with the respiration.
yes, sir. So I have movement with respiration and showing palpation. Sir.
And on inspection, it is not visible. Movements with respiration is not seen. Okay, proceed to palpation.
Sir, on palpation, on superficial palpation, there was no local rise of temperature and the globular lump was palpable.
Then
Then there was no tenderness on repalpation.
no. Second point, sir.
Achha. Yes,
Vague
so
globular lump.
globular lump of approx 5 into 4 centimeter palpable below the right costal margin at tip of ninth rib. Smooth surface, firm consistency. It moves with the respiration, moving side to side, and upper border were not palpable.
So what does this suggest?
So it suggests that it is a palpable gallbladder.
How will you differentiate gallbladder lump from the renal lump? Sphenic lump from the renal lump?
Yes, sir. Since renal lump means if a renal lump is present, so it will be mostly ballotable. It would not move with respiration.
Any other points?
And it would be, means there would be no side-to-side mobility in cases of renal lump.
Okay.
It would be present in gallbladder.
What is plane of this lump?
Yes, sir.
Whether it is intra-abdominal or
Yes,
how
sir.
will you determine whether it is intra-abdominal or extra-abdominal or retroperitoneal? How will you determine it?
So we can differentiate it from extra-abdominal. We can do a straight leg raising test. If the lump palpation is reduced, then it is most probably arising from the abdominal wall. And if it is reduced, then it is intra-abdominal. And if the palpation, if it is more easily palpable, then it is from
In
abdominal
which
wall.
condition we have to go for a head rising test, and in which condition, in which lump we have to go for the leg rising test?
Sir, head reading test can be done in cases of in slump, which is more towards the epigastric or right hypochondrial region.
Epigastric or hypogastric?
Hypochondrial.
Hypochondrium. More specific answer. Above the umbilicus, head
Above the
rising.
umbilicus, yes.
Below the umbilicus, leg rising.
Leg rising.
How will you perform the head rising test?
Then head reading test will ask the patient to lie supine, and then we'll ask him to raise his head मतलब without holding the legs. With
Without?
the 30, we'll ask the patient to flex his head.
So what is the relation of the leg head rising to the contraction of the abdominal wall muscle? Or leg rising with the contraction of the abdominal wall muscle?
Certain leg raising test means the abdominal, the patient will tight his abdomen. They would lead to contraction of abdominal muscles.
How? Basically, in head rising test, to stabilize thoracic cavity, rectus get contracted. In leg rising test, to stabilize pelvis cavity, oblique get contracted. That is basic of these two tests. Now, what are the different methods of palpation of spleen?
Then in palpation of spleen, there is a Nixon's method. In palpation of spleen, so there are two methods. There can be in the first palpation, we move
There
from
are
the
how many methods?
the first method in which we
How
start
many
palpation.
methods are there for Parth? How many methods are there for palpation of the spleen?
Sir, I know about two
Basic
methods.
undergraduate question.
Yes, sir. There are one we start the palpation from right iliac fossa and we move towards the left upper quadrant. And if the spleen is
There are four methods of palpation of spleen. Parth, there are four methods of palpation of spleen. Okay, proceed. Any other faculty? Khanna sir.
But what is the difference between the scratch marks of a jaundice patient and a scratch mark of a patient who has got some dermatological condition?
Sir, in dermatological conditions, erythema would be present around the scratch marks.
What is the abnormality in the case of the obstructive jaundice patient?
Yes, sir.
Regarding the scratch marks, what is the abnormality in the patient with a obstructive jaundice? There is a coagulation problem is there. So the scratch marks of the obstructive jaundice patient, they bleed.
Okay, sir.
While in the dermatological condition, they will probably not bleed. Until in a very severe dermatological condition, then it will be different. But otherwise, mild dermatological condition is there, it will not bleed. While a scratch mark in the case of the jaundice will bleed. What is the pulse rate in your patient?
Pulse rate is 63.
Why it is 62?
Sir, in cases of obstructive jaundice, the bile salts which increasing the blood can lead to bradycardia. Bilirubin itself causes the bradycardia. So there would be towards the lower side. Yes, sir.
Why it causes the bradycardia?
So bilirubin might cause bradycardia because it directly affect the SA node and it decreases its rhythmic pulse, and it also deposits. Means mainly the reason for bradycardia is because it affects the SA node. So the bilirubin which is increasing, it affects the SA node because of its deposition at the SA node.
Yeah, it can deposit on the SA node, it can deposit in the AV node. Then it
Yes.
can irritate the vagus nerve. What is the vagotonic effect of that? And then in the
Yes.
patient with the jaundice, there is a special type of the factor which is secreted, what you call a myocardial depressant factor.
Yes, sir.
Okay, MDF, myocardial depressant factor. So all these they can cause the bradycardia in a patient with the obstructive jaundice. You said the gallbladder lump is palpable and your liver span is 11 centimeter in the mid-clefter line.
Yes,
So
sir.
are you correct in saying that? From your figure, we could see that there was fullness almost going up to the umbilicus. And you're saying the liver span is 11 centimeter.
Yes, sir.
Can you justify that? Are you able to understand my question?
Yes, sir. Yes, I am able to. We can't
Okay, you can
differentiate.
see the fullness which is right up to the umbilicus.
Yes, sir.
Almost up to the umbilicus, yeah. And your liver span is still only 11 centimeter. That is not feasible.
Yes.
Whenever there is a palpable gallbladder lump is there, you cannot tell the liver span in the mid-clefter line. You have to move either laterally or medially.
Okay.
So you can go for the anterior axial line, you can go to the mid-axial line to tell about the liver span, but not in the mid-clefter line, because mid-clefter line there is a gallbladder lump is there.
Yes, sir.
So you cannot tell about that. Okay.
Dr. Abhay Dalvi has raised a hand. See, I think he wants to ask some question to Parth.
Okay, yeah, please. Dr. Dalvi, please.
No, I don't think he has mentioned mid-clavicular and anywhere. He's talking of tip of the ninth rib, which I was scratching my head about. That's all.
No, I think he has written there. Can you go on the next slide?
Yes.
Where you are saying the liver span?
Yes.
Yeah, Dr. Dalvi, it is there.
Okay.
In the
Okay.
mid-clefter.
I missed it. I missed it. It's okay.
Yeah, it is there, yeah. Okay. So what is your diagnosis now?
So my first diagnosis is obstructive jaundice, secondary to carcinoma head of pancreas, and differentials would be it can be distal cholangiocarcinoma, it can be a periampullary carcinoma, but can also be carcinoma gallbladder.
Why you are keeping a distal cholangiocarcinoma specifically here? The reason for that?
The distal cholangiocarcinoma is also present with means painless progressive jaundice.
No, but you are putting a periampullary carcinoma as well. So why the distal cholangiocarcinoma?
So because in periampullary carcinoma, patient will have a history of waxing and waning type of jaundice, plus there will be history of melena, or means there was no such history in that patient. So I have gave a periampullary carcinoma as a lower up below the line.
So you get in all cases of periampullary carcinoma the melena?
No, sir.
Which periampullary carcinoma gives rise to melena?
Ampullary and duodenal carcinoma, sir.
So if it is ampullary in the duodenal is there, that will give rise to the.
Yes,
But
sir.
it can be distal cholangiocarcinoma also a part of the periampullary carcinoma. Can it happen?
Yes, sir. Yes, sir.
It's
If it
around
is
2 centimeters. 2
yes, sir.
centimeters around the ampulla. And that includes the distal cholangio, isn't it? So
Yes,
rather
sir.
than saying separately the distal cholangiocarcinoma, if you just mention the periampullary carcinoma as the second diagnosis, that will be better.
Okay.
Then how do you explain the carcinoma gallbladder in a patient where you are getting a gallbladder lump which is not hard in consistency? It is relatively soft or firm in consistency. How do you explain that?
Yes. So if like if it is originating from the neck and obstructing the cystic duct, then it might it is possible that it would be soft and consistency because of dilation.
Now, what will happen if there is a neck gallbladder?
Like, so there would be distension of gallbladder, which would be, and the lump which is palpable will be soft in consistency. because of secretions would be accumulated inside the gallbladder only, and it would not be
What you call that?
mucosal.
Mucosal of the
Yes.
This is the mucosal of the gallbladder, that is why you are not getting the hard lump there.
Yes, sir.
Right. So how will you proceed with your investigations?
Okay. Sir, keeping this provisional diagnosis, I would first proceed with the ultrasound abdomen to differentiate that to look ultrasound abdomen would be my first investigation.
Okay. So what are the things you are going to see in your patient on ultrasound, theoretically?
Yes, sir. So in ultrasound abdomen, I would like to I would like to look for the intrahepatic biliary dilation of CBD. I would like to look for the lesion where it is originating, and the lymph nodes which are involved, as well as I would like to look for the liver metastasis, as well as like if ascites is present or not, or prefluid is present or not.
Yes. So if you find there is a dilated bile duct, which is not till the lower end, but you are getting the dilatation only in the upper end, what does that indicate?
The dilation is apparent. There might be like in distal part, there would be structured segment might be present. If there is like at the cutoff on the proximal dilation is there. So in mid CBD or distal CBD, there might be structure.
You can have a cholangiocarcinoma also.
Yes, it can be malignant, or yes, it can be malignant structure, and there will be cholangiocarcinoma.
So how will you distinguish whether it's a Klatskin tumor or whether it is a cholangiocarcinoma?
But in cases of Klatskin tumor, if primary confluence is involved, the gallbladder would not be dilated. So a gallbladder would not be distended, lump would not be palpable. But in cases of distal cholangiocarcinoma, this gallbladder lump will be palpable.
Good. Yes. Okay. Then after the ultrasound, what you are going to do?
So after ultrasound, we can proceed with the CCT abdomen with pancreatic protocols.
Now, what are the various ways to obtain the biopsy in a case of carcinoma of pancreas?
To obtain a biopsy, we can the best most accurate method is endoscopic ultrasound.
Good.
To which we can obtain it. And
any other ways to have the histocytology?
To obtain like endoscopic ultrasound through while doing while doing the ERCP also biopsies can be obtained. Yes. And it can be also CT guided biopsies.
Okay. Any further investigation you want to do in a suspected case of carcinoma head of pancreas?
Well, I will also like to proceed with the blood investigation, sir. In blood investigations, I would like to get the liver function test done, in which I would like to see for the bilirubin levels, conjugated as well as unconjugated. I would also like to see for the liver enzymes, amylotransferases, as well as phosphatase and gamma glutamate, phosphatase and aminotransferases. And I would like to get the coagulation profile done, sir, like PTI test. I would also like to get in a blood investigation. I would like to get CBC as well as renal function test. CBC, I would like to see whether patient is anemic or not, or if counts are raised or not. In renal function test, I would mainly like to see for the urea and creatinine levels whether they are raised or not.
Why you have done the CA99 in your patient?
The CA99 can be used as a prognostic marker for the patients in which carcinoma cancer is suspected.
So is it normal or it's raised?
It is normal, sir, in this case.
What is the normal value of the CA99?
So it is ranging from 0 to 37 international units per minute.
Any other tumor marker you want to do?
So tumor markers other than this, we can also get CEA, CA19.9 and CEA can be done. Also for liver, like if we are suspecting liver carcinoma, alpha fetoproteins can be done to see for the metastasis and if they're suspecting. CA19.9, CEA and alpha fetoproteins can be done.
Alpha fetoprotein is for the metastasis?
No, sir, for primary liver cancer.
Hepatocellular carcinoma.
Yes, sir, hepatocellular.
Yeah, Dr. Dalvi, please.
What is pancreatic protocol CT?
Sir, in pancreatic protocol CT, we basically do a CT scan for means in this we take 3 mm slices of pancreas in 3 different phases. One is non-contrast phase. Second
One
is
minute, 1 minute, 1 minute.
yes.
When is it 3-phase and when it is 4-phase?
Sir, 4 phases. In 4 phases, there is early arterial as well as delayed arterial phase. And early arterial phase is
When do you do that? In what conditions?
neuroendocrine tumors of pancreas.
Neuroendocrine. Very nice. I am very happy that you know. The second thing I just want to ask you is why, when your clinical diagnosis is obstructive jaundice and you want to know basically whether this patient is operable or not operable, why do you want to do USG when CT gives you more information?
So USG will tell us that means see, we'll get a CT done, but like by seeing the patient clinically, we don't know the like what is the cause of
1 minute, 1 minute, wait. You have clinically examined the patient. You have come to a
yes.
diagnosis, differential diagnosis of 4 things. Why do you want to do a USG? Why not go directly for a CT and then decide the treatment, how to get biopsy, etc., etc.?
Yeah, so Parth, actually, sir wants to ask you that suppose on ultrasound you see the metastasis in the liver. Will you like to still go for a CT abdomen? You will like to take a USG guided biopsy from that metastatic lesion, suspected metastatic lesion, and if it is proven, then still there is no need to, I mean, go for CT scan. I think this is what sir wants to convey.
No, I want to convey a different thing. I want to convey that CT scan will give you enough information whether to go for CT scan guided biopsy of the liver met or go ahead with further investigations to operate on this patient. That is exactly what I want to know from the student.
Yes, sir.
Okay.
Have I lost the link or?
Yes. So means we can if we want to like look for the receptivity, we can go for CT scan. Yes.
Dr. Dalvi, can I answer on
Yeah,
behalf?
please, sir.
Yeah,
Go ahead.
I think probably the student is right in saying that ultrasound has to be the first investigation in any abdominal lump. There is no doubt about that. Ultrasound is a bedside investigation now, Jay. So it is just a fifth limb of that. After the inspection, palpation, percussion, auscultation, the fifth comes the ultrasound. So I think there is no harm in doing an ultrasound in any abdominal lump, I will say that. Okay, it is not only for this. Because on ultrasound, if you find there are metastasis in the liver is there, then you have to think whether you are going for the CT scan or not.
Sir, I completely agree with you.
Yeah, and definitely ultrasound, the cost of the ultrasound is only 100 to 200 rupees, whereas CT scan will take a lot of things and it is associated with the complications.
Sir,
Like
I am not,
in our one of our patient, we were giving the contrast and the patient developed the acute renal shutdown by that. So
sir,
there's complication of the pancreas.
sir, let me just.
Yeah. No, I'm just, that is just my opinion. Yeah.
No. I have no objection for ultrasound being done as the first line of investigation for sure.
Yeah.
The candidate has to know.
Yes, he has to know that, definitely.
He has to know what other things can be diagnosed by ultrasound with the
Yes.
recent machines which are available. So
Yes.
my next question to the candidate is, whatever ultrasound information you get, what other information with recent ultrasounds can you get?
If like we do an ultrasound, a recent ultrasound, we can also do a Doppler study. Doppler study will tell us about whether there is any means occlusion of like veins, portal veins, superior mesenteric vein, or arteries.
Correct. Congratulations. So when you answer question on ultrasound, you should include all these things and it will give you good marks. That's my Ashirwad.
Prabhat, do you know what is contrast ultrasound? What
Yes,
is contrast ultrasound?
yes, sir.
Nowadays, we
actually
are doing
it
the
is,
contrast ultrasound. Yeah.
so actually it is contrast enhanced ultrasound, that is CEUS.
Yeah. What is that?
Sir, do not know.
You give the patient the micro bubbles, Jay. Okay, and then definitely you can increase the sensitivity and the specificity of your diagnosis by the ultrasound. And then the extension of that is the fibroscan. That is also a type of ultrasound. So you can do the fibroscan for that. So these are
Okay.
all the advancements in the ultrasound are there.
Okay, sir.
Okay. So has the CT scan been done in your patient?
Yes, sir. CT scan has been done.
Show that. Yeah, show that, please.
So the CT scan shows that when there were no metastasis inside the thorax, liver span was normal, and there was no means there was no solid or cystic mass inside the liver, but IHBRDs were present. Gallbladder was grossly distended with hyperdense content as seen within the gallbladder. CBD was dilated with measures 22 millimeter and appears obstructed at the lower end. Left hepatic duct measures 10 millimeter, right hepatic duct 16, and CSD 18 millimeters. Abrupt tapering is seen at the level of distal CBD with ill-defined soft tissue causing an abrupt cutoff. Is seen at 18 to 20 with measures 18 into 20 millimeter. And the pancreas was normal in size and there was no focal lesion. Pancreatic duct is not dilated. And impression, so there is ill-defined soft tissue lesion and thickening with upstream dilated CBDs and IHBRDs, and abrupt cutoff of CBD with tiny deposits in right lumbar region, likely neoplasm.
What is that? Tiny deposits in the right lumbar region?
So there was abrupt cutoff in CBD with tiny deposits to right in lumbar region. Means it was thematic.
Where in the right lumbar region? In which structure? Is the omental metastasis?
Yeah.
Is it the omental metastasis?
No, sir. Omental nodules are not there. And
No, right lumbar region. Can you point out where is that in the picture?
sir, actually, that screenshot is not taken, and I was not able to exactly point out where were these tiny deposits.
Okay. So what is their diagnosis?
So based on CT scan, as it has shown that there is an abrupt cutoff at the CBD and there is soft tissue mass which is obstructing, it might be distal cholangiocarcinoma, sir.
Why not a periampullary carcinoma? Again, the same
Yes, sir.
question.
Well, included periampullary can be there. Periampullary carcinoma.
So how will you differentiate whether it is a cholangiocarcinoma or a periampullary carcinoma?
Sir,
On the CT scan, how can you say that it is
uh,
probably a cholangiocarcinoma and not a? Did you see the pancreatic duct here?
yes, sir. Pancreatic duct is seen, but it is not dilated.
So what does that indicate?
It is cholangiocarcinoma because yes, in periampullary there would be dilation as well of pancreatic duct as well as column-related duct.
So by that, probably you can have an idea that probably
Yes,
it's a distal cholangiocarcinoma because the pancreatic duct is not dilated here.
yes.
Okay. Any further investigation you carried out?
No, sir. This was.
Okay. So what is your plan now? Are you going to do a GI endoscopy in this patient or not?
The upper GI endoscopy is not indicated as because according to CT scan, as the tumor seems to be resectable, so we might prepare the patient for OP because endoscopic ultrasound means there are no signs and like it mainly can be done for gastroesophageal varices, but there are no signs of like cirrhosis or hypertension or ascites. And so we generally like endoscopy through endoscopic ultrasound if we need biopsies. So if the cases are resectable, so the biopsy is not needed. We can directly go for this.
I think still for the academic purpose, you should go for a side viewing endoscopy in this patient. Okay, side view endoscopy has to be done to see for that periampullary mass there. So that has to be carried out. And in case if you want to drain that bile, okay, so you can add on to that. What is the bilirubin level in your patient?
32, sir.
Hmm?
32.
It
Total
is
bilirubin was
32.
32. Direct was 15. Yes.
So if the bilirubin is 32, I think probably I will like to put a stent there before I go for a definitive surgery in this patient. Okay. Up to 15 is a cut-off line that. Up to 15, you can go directly with the surgery. But if it is more than that, then it is better that you drain that. Okay. So was this patient discussed in the MDT team?
Yes, sir.
Was your patient discussed in the MDT? Multidisciplinary team?
No,
What
sir.
has to be
Currently,
done?
his radiological discussion was carried out, but currently patient was recently admitted, so that discussion was multidisciplinary.
Okay, ideally, your answer should be that
Yes, sir.
such patients has to be
Should
discussed in the MDT,
Yes,
na?
MPT. Yes, sir.
And then decided what to do. So what is your plan in this patient now? Tell about that.
Sir, as it is a it is a resectable tumor, so we can go directly for the surgery and we'll plan for Whipple's procedure.
Are you sure it's a resectable tumor?
Uh, yes, sir. So there are no metastases and
But you are
means,
saying that the metastasis in the right lumbar region. You yourself are saying that
yes, sir,
there
but
is in the right lumbar region.
so they were actually just tiny deposits. It was
Even if the
metastasis.
tiny deposit is there, that's suspicious. You have to further investigate your patient. What is that investigation which will decide whether you can go for a definitive surgery or not?
If we suspicious that that is metastatic lesion, we can go for the FDG PET scan, sir.
Okay, you can go for the PET scan.
If,
That is
if
one
we want
possibility.
to do a metastatic workup.
Yes. And laparoscopy? Can you do the laparoscopy?
Yes, laparoscopy can be done. Yes.
It has to be done in your patient. Before you take up the patient, making a big incision for that patient for carrying out the Whipple's operation, you must do the laparoscopy in this patient,
Diagnostic
at least to
laparoscopy.
see. And if you find there omental deposits are there, you stop there. Okay. Or you can go for a palliative surgery on the not for a curative intention.
Yes.
Okay. So, is the patient operated or not?
No, sir, not correct.
Okay, let us say that we are planning this patient for the Whipple's operation. How you are going to prepare your patient?
So pre-operative preparation first, there are many things which you need to important things are first, as patient will be in dehydration because it is an obstructive jaundice. First, we need to resuscitate the patient with IV fluids. We need to see his renal functions there by doing renal function test and giving patient IV fluids. Then we need to see for the anemia. If patient is anemic, we need to optimize his hemoglobin. Second is in cases of these cancerous cases, there is a depletion of glycogen storage. We need to restore the carbohydrates by giving carbohydrates to the orally. We can allow patient carbohydrates. Uh, uh, yes, sir. Answer for
What about albumin?
yes, albumin can also be given. Yes, sir. In cases of the too low, then albumin transfusions can be given. If the patient is too much cachexic, then PPM can also be started for the patient.
Yeah, Dr. Dalvi,
Yes,
please.
sir. And for pre-operative preparation, we also need to get if
Dr.
like
Dalvi wants to ask.
yes.
Dr.
Tell me
Dalvi, please.
tell me difference between acute dehydration and chronic dehydration and when and how obstructive jaundice does that.
Sir, have to, yes, sir.
If you don't know, you say don't know.
I do not know, sir.
In obstructive jaundice, it's a chronic dehydration which has to be corrected periodically and slowly. You just can't give albumin, etc., and 48 hours you take the patient table. Dr. Khanna, I think you should enlighten these people on this.
Okay, Parth. Go on telling about the preparation.
And sir, for the preparation, we'll also like to optimize, generally these type of cancers occurs in old age. We need to get a cardio clearance or to deco, and we also need to start like chest physiotherapy for the patient or strength center spirometry for the patient, so that preoperatively, so that means for the preparation of it.
Did you mention anything about the correction of the coagulation parameters?
Yes, sir. Coagulation profile has to be corrected, and yes, sir, we have to give vitamin K for that to the patient, and we have to also look for like obstetric patient present with itching also. So we might add like antihistamines to the medication so that itching is resolved.
Now, which vitamin K you are going to give and how much you are going to give?
So a injectable vitamin K, we can give it for 3 days, 4 days, 10
Which
milligram OD.
vitamin K is that? What is the name of that vitamin? There are different vitamin Ks are there, no?
Yes, sir.
So which one you are going to give? Usually methandion, no? Okay, it is. And how much you are going to give?
So 10 milligram IV OD
For how
for
many
3
days?
for 5 days.
3 to 5 days, no? 3 to 5 days, okay.
Yes.
Right. Now, if you still think that the coagulation is not good, what else you can do?
So we can transfuse FFP to the patient, fresh frozen plasma to the patient to improve the coagulation profile.
Now then, it's a big debate whether you do a pre-operative drainage or not. So
Yes,
what
sir.
is your concept about that? Which patients should be drained?
Recently, it has been shown that the pre-operative drainage means if it like in pre-operative drainage, where there means only if there is cholangitis, then only patient means requires in resectable cases if patient is going into cholangitis, then only means preoperative biliary drainage should be done because so there are many complications of preoperative biliary drainage. First is like there is a high risk of wound infection in the post-operative period. There are also complications of stents. There may be stent migration, and if there is a stent is placed, that stent get again and again blocked. So means actually there is no difference between the if it is we see in the cases of we directly go for OT and we for the operation and we directly go for preoperative biliary drainage. There is no difference between survival rates and morbidity. But just there is difference. There is long time hospital admission and again readmission in cases of preoperative biliary drainage has been seen, and also increased chances of wound infection post biliary drainage. And if we are anyway, if we are doing preoperative biliary drainage, sir, at least we should wait for 6 weeks because the effect of preoperative biliary drainage on means regaining the functions of liver or regaining the function there in cases of obstructive jaundice, patient has liver dysfunctions as well as there is renal dysfunctions. So these are like coagulation profile also drainage. These are all corrected after 6 weeks. And means if we are doing the preoperative biliary drainage, surgery should not be planned within 6 weeks.
What is the surgeon's nightmare if the drainage has been done?
If so, one thing is means patient might mostly patient might get a stent block or stent migration.
No, but what is the surgeon's problem?
Sir, if
If the bile duct has been drained or stented, there's a
yes.
lot of adhesions are there.
Okay.
And that is
Yes.
the surgeon's nightmare. No?
Yes. Sir.
But if it is a stented one is there, there's a lot of the adhesions are there. It becomes a very difficult surgery. And that is a majority of the surgeons will not like to drain or put a stent if they are planning for the VPS operation.
Yes.
Now, when the mannitol is required, do you give the mannitol in these patients? Or what is hepatorenal shutdown?
Say hepatorenal shutdown in these cases means there is a hepatorenal shutdown in cases of obstructive jaundice because of increase means there is There is how it is caused, sir? Hepatic venous shutdown basically because of obstructive jaundice. If there is renal dysfunction, then it is.
So
It will be
why there is hepatorenal shutdown?
shutdown. Sir, it is
What are the
basically
main
because.
causes of hepatorenal shutdown?
Yes, sir. So first thing is these the bilirubin which is increasing or the bile salt, it causes the vasoconstriction over the efferent arterioles. These vasoconstriction lead to decreased blood flow, and it eventually will lead to renal dysfunction. Second thing is if there is also decreased cardiac output in these cases. So decreased cardiac output also leads to means uh, decrease flow to the renal vessels, and there would be renal shutdown. One other thing is, sir, there is also increase in endotoxins in these cases because as the liver is there is a liver shutdown, liver is not able to metabolize the endotoxins. These endotoxins triggers the inflammatory reactions, which lead to fibrin depositions within the efferent arterioles, and these also lead to the decreased blood flow. So because of these causes of decreased blood flow, there would be decreased blood flow towards the cortex of the kidney, and it would eventually lead to tubular necrosis and all. So
Good, yeah.
this will lead to
But
hepatorenal
the two main reasons for the hepatorenal shutdown, one is the hypotension,
hypertension. Yes,
and
sir.
second is the gut barriers which are there. So you have to take care of these two things, that your patient should not go into hypotension, and you have to take care of the gut barriers. So how can you take the gut barriers? What can you do for that? You can give the patient the lactulose.
Yes, sir.
You can prescribe the patient the lactulose, and you prescribe the patient the prophylactic antibiotics.
Yes,
To
sir.
check for the gut barriers. Okay. So these are two important things to avoid. And that is why sometimes you have to give the patient the mannitol also to flush the kidney, because these bile salts, they get deposited in the tubules. So for that, you can give the patient the mannitol if there is a patient has a high bilirubin. Dr. Dalvi, please.
He is good. So I just want to take him away from obstructive jaundice because of malignancy. So tell me, what are the non-malignant, non-operated causes of biliary obstruction?
So there might be non-malignant causes can be like there will be CBD stone, which can lead to eruption jaundice,
Remove,
and
remove the CBD stone also. Non-malignant, non-stone, non-operated causes of biliary obstruction.
so there may be benign biliary stricture, and
Due
there
to,
may be
due to
so it is most common due to laparoscopic post laparoscopic cholecystic
I
trombus.
have said non-operated patients.
Okay. In non-operated cases, benign biliary stricture would be most probably if there is a
What is primary cholangitis?
Sclerosing cholangitis, yeah. Go on the
yes, sir.
sclerosing cholangitis, yeah.
Yes, sclerosing cholangitis can.
What is it? What is it?
Sir, it is an
I'm
autoimmune
asking you
disorder.
these questions because you're good.
Yes. So there is means it is autoimmune disorder in which the antibodies are formed against the biliary epithelium, and it leads to depositions in the means bile duct and canaliculi, which further leads to sclerosis. And this
In
all
which
leads to
condition,
stasis, and
in
stasis
which
causes.
condition you get the sclerosing cholangitis?
So
In which
it is
condition you get the sclerosing cholangitis?
it is associated with ulcerative colitis, sir.
Inflammatory bowel disease, you know?
Inflammatory bowel disease, yes.
Okay.
My second question to you is, name a paper which has been published from India giving rise to obstructive jaundice. Give you a hint, North India. Kuru's paper.
Okay.
From Srinagar.
I do not know it.
It's okay. It's okay. You're good. You're good. Roundworms obstructing the common bile duct was the paper which was published by Dr. Kuru from Srinagar. I just wanted to get into how much more you have read into obstructive jaundice, but you're good.
Okay, Parth, you have prepared your patient for surgery and your plan is to go for a pancreaticoduodenectomy.
Yes, sir.
Patient is on the table. What are you going to do now?
Means, like, first pre-operative, we have to do the surgical checklist, sir.
Everything has been done. The patient has come on the table. The patient has come on the table now.
So we have to check for the vitals, well, patients, and like.
Oh dear, you are the surgeon.
Starting this.
Now you are going to, the anesthesia will be given and you are starting on the surgery.
Yes, sir. We'll start with the chevron rooftop incision, sir. And with the for pancreaticoduodenectomy, we'll first open the lesser sac and then
You will directly open the lesser sac as soon as you enter in the abdomen.
No, sir. First, sir, we have to make first. If patient is on table, first we'd also like to do diagnostic laparoscopy.
Yeah, so
yes, sir.
You have to do a diagnostic laparoscopy in this patient.
Yes.
And then you will proceed with that. Right?
Yes, sir. Okay.
So what are the things you are going to remove in classical Whipple's operation?
So in Whipple's operation, the duodenum with the head of pancreas and distal 10 centimeter along with the jejunum and distal stomach with CBD and gallbladder is removed.
How much distal stomach?
50% of distal stomach.
50% you will remove that.
Yes, 40 to 50%.
If I stand corrected, probably distal 1/3 of the stomach.
Okay.
Not 50%, distal 1/3 of the stomach. Yeah, Dr. Dalvi, please.
You put in a laparoscope and you find single metastasis proved by frozen section on the falciform ligament. How will your treatment change? I'm asking these questions because you are good.
So it is.
You find a single small nodule on the falciform ligament, which you send for biopsy. It comes positive for metastasis from adenocarcinoma. Now what?
So we'll abandon procedure. We'll go for the neoadjuvant therapy.
But patient has obstructive jaundice.
Yes, sir.
He is not stented.
Yes, sir. Yes. So we'll go for the triple bypass, sir. Means we'll do the bypass surgeries, but and then send to the patient to the neoadjuvant.
Agreed.
Yes.
What bypass you will do?
So we generally do triple bypass, sir, in which we do the hepaticojejunostomy, gastrojejunostomy, and jejunostomy. And primarily we do not remove the primary.
Okay. Tell what are the various palliative procedures for the carcinoma head of pancreas?
Sir, in palliative procedure,
What are the things you want to palliate in carcinoma head of pancreas?
Yes, sir. First thing is I want to palliate if there is jaundice, I would like to palliate for that. Then
so why you want to palliate the jaundice? Why you palliate the what is the problem? Jaundice is causing problem. Why you want to palliate the jaundice?
Because of patient might go into cholangitis.
Which is the most irritating thing for the patient of obstructive jaundice?
Okay, we want to because of itching. Sir.
Yeah, it's the itching.
Yes.
Yes. That is the most worrisome presentation for the patient. Yes. So because of that you want, and definitely it can lead to all complications. That is why you want to palliate the jaundice. Okay. So one is jaundice. What else?
Second thing is if there is obstruction, I'd like to do the gastrojejunostomy to occlude that obstruction. And the third thing is I would like to palliate for the pain, sir.
Okay.
By giving the celiac plexus work either intraoperative or through ultrasound imaging.
Yeah, Dr. Dalvi, please.
This patient has had no pain that is in your presentation. That's number one. Number two is this patient has obstructive jaundice with itching, which is going all around. Now, you have put in a scope, you have found that he has got a metastasis in falciparum ligament, and obviously, radical surgery is not going to help him. So, what are the things that would go in your mind, and pre-operatively, how will you actually tell the patient and the relatives how to go about your plan?
So pre-operatively, I would like to I would explain them. I would counsel the patient about that there can be this might intraoperatively there might be chances that it is unresectable or it might be found that it is advanced disease. So in that cases, we'll abandon the procedure. Will do means I will explain him about the triple bypass and the stenting, and will counsel them to go for the need for neoadjuvant therapy in pre-operative period only, sir.
Good. Now, if this patient is followed up, what complications can develop if this patient is stented?
Yes, sir.
Because the patient is inoperable and this patient is stented.
So most common complications that are found in the stenting is stent block immediately, immediately within a few periods after for this after stenting, and there might also be stent migration of this patient.
Let's say this patient has got a successful stenting with a self-expandable stent and the bilirubin has come down and the patient looks happy. What are the other complications that you envisage with stent in place? I'll give you a clue. This patient suddenly complains of dark colored stools which he has never experienced, and there is an episode of dizziness.
Yes. So there might be internal bleeding, erosion of the vessels.
Very nice. Which vessels?
So most commonly it is superior gastroduodenal artery might get eroded while the procedure, or there might be like while stenting, also we do the papillotomies and all, that might also lead to bleeding from that point.
Very nice. Very nice. I'm extremely happy with your answers. What will you do?
So first, it will be managed in the terms of hypovolemic shock only, sir. And means first we'll resuscitate the patient, we'll give the PRBCs and transfusion, and if the patient is not responding towards the conservative management, we'll like to explore for the ligation.
What are the options with you in your angiogram? I know you will say angiogram. What are options with you to stop this bleeding?
So angioembolization can be done.
Very nice.
Yes.
Angioembolization is done, bleeding has stopped, but the patient is not improving. Now what will you do?
So we'll reassess and so we need to find the cause why patient is not improving.
Exactly. Has the patient bled too much?
Yes, sir. Might be possible.
Could be.
Yes, sir.
So what are the various supports that you would like to give this patient when you know that your intervention is successful? I'm asking you these questions purely because you're good.
Yes. Supports, didn't get the question. So which supports? Means a patient is not improving.
No, you are sure that bleeding has stopped. Patient is in ICU on
Yes.
ventilatory support, let's say.
Okay, sir.
What are the measures as a surgeon you would like to look at whether you are the cause for the eventual mortality or we are doing everything possible for the patient to prevent this mortality?
Sir, if we need to check if even if the bleeding has been stopped, but if there was means there was too much of bleeding, then we need to check for the hemograms and means transfuse the blood products to the patient. Plus,
Who are the people who will call in to help you in this? I'm asking you this question because we talked of disciplinary things.
yes, sir. Like for angioembolization, we need help of interventional radiology people from these for 20 seconds, and if patient is not improving, we might also require help of anesthesia in the post-op setting, so ventilators and
Okay, let's come back to surgery.
yes.
You are trying to do a Whipple's. How would you decide on gastrojejunostomy against the other procedure for pancreatic anastomosis?
uh, gastrojejunostomy.
Okay, he wants to ask pancreaticogastrostomy or pancreaticojejunostomy.
Correct.
Okay. So we'll go for pancreaticojejunostomy.
Why?
Because it was seen in the pancreatic gastrostomy, there is more chances of anastomotic leak. And with gastrostomy, it would be difficult. Means there are more chances of. No, sir. Currently, I'm not able to recall.
In which case you prefer to do a pancreaticojejunostomy? In which case you prefer to do a pancreaticogastrostomy? What are the two technical things which decide? Okay, what is the texture of the pancreas?
Okay.
It's soft or it is firm to hard? And second is, what is the diameter of the pancreatic duct?
Okay.
So these are two things which decide whether you will prefer to go for a pancreaticojejunostomy or pancreaticogastrostomy. Okay?
Okay.
What did you do?
Yes. We'll go for means like if we go for pancreaticojejunostomy because means
It's okay.
hmm,
Suture material.
suture material we can do polydioxane sutures. Yes.
Is your
PDM.
patient operated? Have you operated your patient?
No, sir. No, sir. No, sir.
No. Okay.
His plan is to do. So what 0?
30, sir.
30. Polypropylene, polydioxane. What do you want to use?
Polydioxane sutures.
Would you like to do something else to secure an anastomosis?
So to secure an anastomosis, like to secure a pancreaticojejunostomy anastomosis, we could while doing the procedure, we can we could cover the anastomosis with the help of the jejunal loop itself.
That's fine. Anything stent, anything would you like to put?
Yes, sir. We like to put a pancreatic stent would be placed inside, and over that anastomosis will like.
What is the caliber of the stent?
It would depend on the diameter of the pancreatic duct.
But you should know that diameter beforehand since you have done the CT
Yes, sir.
or MR.
Yes.
So let's say it is 7 mm.
Yes, sir.
So
we'll like that stent to be stably fit. So we'll use of it's approximately of the same size, 6 to 7 mm. So that is
can you just tell me what things you'll keep in the theater to have a secure anastomosis? diameter of the stent that you would like to put in, and what would you order beforehand to see that there is a stent placed across the pancreatic anastomosis?
To check for the stent position.
Position nahi, size of the stent here, bhai.
Do not know.
I don't know whether you're listening to me or whatever it is. It's okay. Doesn't matter. You got to prepare yourself for all these things.
Sir, can I say something?
Yeah, go ahead.
Yeah. So actually, regarding the conversation about the pancreaticogastroscopy or a pancreaticojejunostomy, as Dr. Khanna mentioned, I think now we have enough evidence, and there are certain meta-analyses on that it is purely on the surgeon's choice. There are centers which are routinely doing pancreaticogastroscopy in any duct size and any texture of the pancreas. And it is surgeon to surgeon, whatever the duct size and whatever the texture, they are comfortable with pancreaticojejunostomy. So I think that debate is closed, that what you should do and when you should do. If you are comfortable with pancreaticogastroscopy, you should go ahead with that. And if you are comfortable with PJ, then you should go ahead with PJ, whatever the duct size and whatever the texture of the pancreas. Now, we have very good, fortunately, very good suture material, very good magnifying loops, and very good hemostatic devices. So I don't think that the leak rates, as far as concerned in PG or PJ, they are almost similar.
Dr. Gupta, I just wanted to know whether he has seen one anastomosis. What the unit wants to do is not my domain. I just want to say that this resident has presented so well
Yes.
that I expect him to know much more than what he's presenting. But
Yes, sir,
he floored all examiners,
Yes.
I
Yes, sir,
don't
I will.
come into picture just like this. When the boy is good, I have to credit him. And
Yes, sir.
that's why I have been asking these questions. Please don't misunderstand me.
No, sir.
Okay, Parth, can you tell us that what are the various ways to palliate the jaundice in a case of carcinoma of pancreas?
So we can, for the jaundice, we can go for the biliary stenting, endoscopic guided biliary stenting.
Yes.
And we can also go for the surgical methods, like we can go hepaticojejunostomy. We can do choledochojejunostomy or cholecystojejunostomy and
Now,
cystojejunostomy.
how you decide whether you can go for a cholecystojejunostomy or not?
Sir, it is depending, means it should be, means if we are doing a cholecystogejunostomy, the cystic duct should be free.
Good.
Then only we can do.
So how will you decide that?
So we can, we can inject dye through the gallbladder and we can see if it is coming through the CBD.
Okay.
Then cystic duct is intact. Yes.
You know, there is some, just by aspirating the bile, can you decide that whether you can go for that or not?
Yes, sir. If we can aspirate it from the gallbladder, and if if the bile is there, if it is a chronic distension, it would be white in color. But if the bile is present, then if fresh bile is present, then the cystic duct is infected.
Okay, if you aspirate the gallbladder, there can be two things. Either it will be a white bile or it will be a green bile.
Yes, sir.
If it is green bile is there, you are happy that
Yes.
you can go ahead and do a cholecystogejunostomy. But if the white bile is there, it can be either because the white bile is coming from the liver or it is the obstructed neck of the gallbladder is there and there is a mucocele is there. That is why you say white gallbladder,
Yes.
white bile which is there. So what next you should do? If it's a white bile is there,
we can aspirate through the hepatic duct. If it is
Yes.
coming from the liver, then white bile will be present in hepatic duct.
Right. So you put a needle in the common hepatic duct.
Common hepatic.
If it is green is there, but the gallbladder is white, it is obstructed bile duct, obstructed cystic duct is there.
Yes.
But if both are white, then probably it is the
Coming from the
patent cystic duct is there. You can go for the polycystic.
Yes.
Any other way by which you can do a, so one you said the ERCP, you can put a stent there.
Yes, sir.
You can do a surgical palliation. Any other way to palliate the jaundice?
Mm,
You can do the percutaneous transhepatic.
okay, yes, sir.
PTVD can be done.
PTVD can be done. Yes, sir.
Can you do endo ultrasound?
Endoscopic ultrasound guided stents can be done. Yes, sir.
You can do the endo ultrasound also, and do a bypass there.
Yes.
Now let us take another scenario that jaundice is because of the carcinoma gallbladder and there is a block at the porta hepatis is there. That is the commonest cause of jaundice in the patient with CA gallbladder. Then what are the surgical options? Surgical options.
Then, if it is obstructing the porta hepatis, then okay. So we can go for the third segment bypass.
Good. So you can go for a segment 3 bypass.
Segment 3 bypass.
Okay.
Yes.
Or sometimes you can go for the segment 5 bypass. Why
Yes.
you choose the segment 3? What is the reason for that?
So there is a fusion of secondary biliary radicals at the third segment.
No, segment 3 is a
Yes,
superficial
segment 3 is
duct. You know?
superficially, yes, sir.
Okay, it is a relatively superficial and straight duct.
Okay.
And that is why you choose the segment 3. Now, if you are not able to find the segment 3, can you do some other operation? You know what is Longmire's operation?
No, sir.
Okay, Longmire's operation is where you chop off the left lobe of the liver and to see the duct there, dilated duct there, and do the anastomosis there. Okay, nowadays these are all not done, but these are certain options which can be carried out in the blocked porta hepatis here. Okay, I think Dr. Kennegavel. If any other examiner wants to ask anything, whether we can stop here. Is Dr. Kennegavel there?
Good evening, sir.
Yeah, Dr. Kennegavel.
Yes, sir.
Can we stop now?
Yes, sir. Maybe we should allow the candidate to ask questions now that he has undergone all the national level questioning.
No, he's a very good candidate. Very good candidate. Yeah.
It shows the amount of
as Dr. W was saying, yeah, absolutely marvelous candidate. Yeah.
Credits to him and to the teachers. Thank you, Amit sir, for kindly permitting him to be with us today. And Dr. Parth, would you like to add up anything? You want to ask any doubts to the examiners?
Yes, sir, correct.
You have any questions to get clarified?
Dr.
The more you
Dalvi,
study, more uncertainties come in. So,
yeah,
Abhay sir,
Dr.
please.
Dalvi wants to ask something.
Yes, sir. Yes, sir. I saw his hand going up. Abhay sir, good evening, sir.
Good evening. I can tell you this candidate is extremely good. He has to be extremely careful with age-old candidates, examiners who will get into him, and somebody should train him. That's.
Thank you, sir. Thank you, sir. Any questions from your side, Dr. Parth?
No, sir. Not correct.
Right. Any faculty would like to give any comments, sir, before we close for the day?
I think Parth presented well. He was quite articulated and as very learned and very experienced examiners, Dr. Dalvi and Dr. Khanna has examined him and they have asked several questions from, I think he was quite confident in answering them. And Parth, whatever you could not answer, please try and read them carefully. Whatever mistakes, little mistakes you committed, please go for correction. Right?
Sure. Thanks.
Congratulations to you, Dr. Amit, also.
No, sir. We are blessed by your experience and this thing. He's really a good boy, very sincere, very dedicated, and very hardworking boy.